Good evening, everyone. We are waiting one more minute and then we will start. I think we can start. So, good evening, everyone, and welcome to our webinar on insights into tonsillectomy and tonsillotomy in pediatric obstructive sleep apnea syndrome. My name is Vlad Pleshka, and I'm honored to be your moderator this evening. Before we begin, I would like to speak on behalf of the pediatric subgroup of young CORL HNS and extend our thanks to each of you for joining us tonight. We have an excellent lineup of speakers who will share their expertise on key topics within this field. Our agenda for this session is as follows. First will be Dr. Palma Benedek. She will discuss about tonsillectomy versus tonsillotomy in obstructive sleep apnea syndrome. Next will be Professor Dr. Anne Baudouin. She will address persistent obstructive sleep apnea syndrome post-adenotonsillectomy. And finally, Dr. Giovanni Camarotto will present on impact of artificial intelligence in obstructive sleep apnea syndrome detection. A few housekeeping notes. Please ensure that your microphone remains muted along the presentation. If you have any questions, feel free to submit them via Q&A function. The session is being recorded and a recording will be made available after the webinar. Please join me in welcoming our first speaker, Dr. Palma Benedek. She is an associate professor of ENT at Paul National Pediatric Institute, chair of the Rhinology and Sleep Surgery section in the Hungarian Society of Otorhinolaryngology. She is also board member of the Hungarian Sleep Society and representative of Hungary in the Council and member of the Standing Scientific Committee of ESPO. Please, Dr. Benedek, you can start.
So, thank you very much. Good evening, everyone. I share my screen. Okay. So thank you for the invitation. This evening, I will be presenting comparative studies of intra and extracapsular tonsillectomy procedures to illustrate how tonsillotomy could be an effective alternative to traditional tonsillectomy. So I will talk about the obstructive sleep disorder breathing itself, the anatomy and the blood supply of the tonsils, the procedures, and the advantages and disadvantages of intracapsular tonsil surgeries. So let's start with the definition of obstructive sleep disorder breathing. This is a syndrome of upper airway dysfunction during sleep, characterized by snoring and/or increased respiratory effort due to increased upper airway resistance and pharyngeal collapsibility. It's important that it's not a distinct disease. This is a syndrome of upper airway dysfunction. As a multifactorial disorder, pediatric sleep apnea has multiple phenotypes. The vast majority of our otherwise healthy patients are in the type 1 group, which is characterized by adenotonsillar hypertrophy. We have several treatment options. In mild cases, we could wait and see, and we have the medical and surgical possibilities. In the medical treatment, in mild sleep apnea patient, we could use anti-inflammatory therapy with montelukast and intranasal corticosteroid. In patients with craniofacial malformation and high arch palate, we have the alternative therapy such as rapid maxillary expansion. We had the positive airway pressure therapy in children as well. And in positional sleep apnea, we could use the positional therapy. The surgery depends on the underlying cause. The most common surgical procedure is adenotonsillar surgery in this patient population, but we often perform inferior turbinate reduction, tongue-based surgery, and supraglottoplasty based on the underlying conditions. In 2020, in our International Pediatric Otolaryngology Group Consensus on the Diagnosis and Management of Pediatric Obstructive Sleep Apnea, experts agreed that adenotonsillectomy is the first-line surgical treatment for sleep apnea in healthy children aged between 2 and 18. However, there was no consensus regarding intracapsular versus total tonsillectomy as the procedure of choice, and at that time, only 30% of the experts recommended intracapsular tonsillectomy. So a few words about the anatomy of the tonsils. As we know, the tonsils are located in the tonsillar fossa between the anterior and posterior tonsillar pillar, covered by a fibrous capsule, which links them to the wall of the pharynx. The blood supply is provided from 5 arteries, as you can see here. And I would like to highlight this branch of lingual artery, which could be extremely close to the lower pole of the tonsils in small children. So it could be a dangerous situation during extracapsular tonsillectomy. And another problem could be the internal carotid artery, which could lie within 1.5 centimeters from the fossa in children under 11 kilograms. So essentially, younger children are more vulnerable to severe bleeding as a result of extracapsular tonsillectomy. The tonsils are placed at the gateway of the respiratory and gastrointestinal tracts. As we know, they are the first line of our immune defense as a part of a mucosa-associated lymphoid tissue with several immunological functions. They are most active before the onset of puberty. However, this activity persists throughout the individual's life. After tonsillectomy, the level of the secretory EGA is decreased, although it remains in the normal range. So let's talk briefly about the history of tonsil surgery. Tonsillectomy was first performed by Celsus in the 1st century before Christ. He used his finger for the dissection. Tonsillotomy was first performed in 1910 with the tonsil guillotine, and later in 1999, Elizabeth Holt-Krantz published her laser and radiofrequency tonsillotomy methods. And in 2003, Professor Peter Kortai introduced his power-assisted intracapsular tonsillotomy using a microdebrider. Adenotonsillectomy is the most common surgical procedure in children. According to the latest American Academy of Otolaryngology guideline, the indications for tonsil surgery are the following. Obstructive sleep-related breathing disorders in patients with adenotonsillar hypertrophy, recurrent throat infection if a patient has at least 7 episodes of throat infection in the last year, or 5 episodes per year in the past 2 years, or 3 episodes per year in the past 3 years. Other indications are the periodic fever and the history of peritonsillar abscess. Naturally, as a surgical procedure, tonsillectomy could have complications. The overall mortality rate is 1 per 55,000 procedures. The most common complication is the bleeding, which could be primary or secondary, and its rate is between 1 and 3%. Other complications could be the prolonged postoperative pain and dehydration. In patients with obstructive sleep apnea syndrome, pulmonary edema can be developed, and rarely we can find Grisel syndrome and parapharyngeal abscess. In patients with sleep disorder breathing, a hypertrophic but healthy tonsil need to be removed. So this has led to a demand among ENT experts for a less harmful procedure, which has resulted in the development of tonsillotomy. This slide shows the different types of tonsillectomy: the extracapsular tonsillectomy, intracapsular tonsillectomy, and tonsillotomy, which is the partial tonsillectomy. The main difference between the extracapsular and the intracapsular form is that the capsule is resected in extracapsular tonsillectomy while remaining intact in the intracapsular forms. We resect 100% of the tonsils during extracapsular tonsillectomy and almost 100% during intracapsular tonsillectomy, in contrast to the less than 75% of the tonsil resected during tonsillotomy. Intraoperative and postoperative bleeding is less during intracapsular forms, and patients experience less pain after intracapsular tonsillectomy than after extracapsular tonsillectomy, according to the literature. The benefits of intracapsular tonsillectomy come from the preservation of the tonsillar capsule. This procedure results in reduced postoperative pain, decreased painkiller requirement, and lower rate of readmission due to dehydration. The postoperative bleeding and the time to return to normal activity are decreased, and part of the tonsil is preserved with its immunological functions. A large number of studies in this topic can be found in the literature. The study from last year compared the postoperative bleeding in tonsillectomy versus tonsillotomy. The overall bleeding rate after tonsillotomy was 3.9% compared to the 9.5% after tonsillectomy. They found a significant difference in the surgical bleeding control and the readmission rate as well. And they concluded that older age and tonsillectomy were the most significant risk factors for postoperative bleeding. In this meta-analysis, authors compared the short-term complications of the procedures. It contains 15 randomized control studies. The risk ratio for postoperative bleeding was 0.44, and they suggested that intracapsular tonsillectomy can effectively reduce pain and bleeding, and there was no difference between the techniques. It helps in the return to normal diet and activities. There was no significant infection after intracapsular tonsil surgery, and there was no advantage in using intracapsular versus extracapsular tonsillectomy in relation to sleep disturbance and quality of life. Our findings are consistent with the current literature in the topic. In our previous study, the overall bleeding rate was 3.07%. The bleeding rate after tonsillectomy was 4.47%, and the bleeding rate after tonsillotomy was 0.95%. There was no difference in the surgery time, and the scar detached earlier in the tonsillotomy groups. They needed less painkillers, and they could return to the normal diet and activity earlier than patients in the tonsillectomy group. The main concern about the intracapsular tonsil surgery is the regrowth of the tonsils. Here you can find two studies on this topic. The first is a large cohort with more than 2,500 patients with an 8 years follow-up. The short-term complications were the same as we mentioned above. The long-term complication, the regrowth rate was satisfying. It was 0.21%. And they concluded that it is related to the near complete removal of the tonsils. This other study from this year with a 12-year follow-up, there was no difference in the quality of life and the throat infection, and the reoperation rate was 6.9% in tonsillotomy, and they concluded that the long-term clinical effectiveness of tonsillotomy seems excellent. The last study I would like to show you today is the study from last year when authors examined the revision surgery rate of coagulation intracapsular tonsillectomy in a 9-year period. The overall revision rate in this study was 3.3%, and the revision rate was highest among children under 2 years. And if they excluded them from the analysis, the revision rate was 0.4%. The authors highlighted that not only the patient age, but the experience of the surgeon in the procedure was also a significant risk factor of the regrowth. Our preliminary data on the effectiveness of tonsillotomy can be seen here. This is a 5-year follow-up study. Our overall reoperation rate was 4.86%. The reoperation rate above 3 years was 3.2%, and it was much lower above 4 years. It was 1.8%, and it was the highest among the patients under 3 years. It was 13% in this age group. We examined the severity of sleep apnea as well, but we didn't find correlation between the severity of sleep disorder breathing and the regrowth rate. So in conclusion, we could say that the intracapsular tonsil surgery's short-term effect is favorable. It effectively reduces pain and bleeding, helps in the return to normal diet and activities. Sleep disturbance and quality of life results are the same as after tonsillectomy. And the potential long-term complication is the regrowth of the tonsils, which is related to the age of the patient and the proportion of the tonsil that was resected. The intracapsular tonsil surgery is not only associated with lower short-term postoperative complications compared to extracapsular tonsillectomy, but the long-term results are also satisfying in patients with sleep disorder breathing. So thank you for the attention, and I hope we could discuss it in person on the next ESPO meeting in Stuttgart in May.
Thank you very much, Dr. Benedek. Now we propose to leave all the questions answered at the end. So it's my pleasure to introduce you now Professor Anne Baudouin. She is head of clinic in pediatric ENT at Antwerp University Hospital, Belgium, and associate professor of pediatric otorhinolaryngology at the University of Antwerp, Belgium. Professor Baudouin is executive board member of the European Society for Pediatric Otorhinolaryngology and co-author of the European Respiratory Society Task Force papers. He is also core member of the European Respiratory Society Clinical Research Collaboration, iDREAM, on the diagnosis and management of sleep disorder breathing in children less than 2 years old. Her main research topics in the field of pediatric obstructive sleep apnea are drug-induced sleep endoscopy, multidisciplinary management of pediatric obstructive sleep apnea, and also OSA in infants and in children with comorbidities such as obesity and Down syndrome. I know we're all eager to hear from Professor Baudouin, so let's get it started. Thank you.
Thank you so much for this kind introduction. It's an honor to be here and to talk about our experience in the management of persistent sleep apnea after adenotonsillectomy. So I first will give some definitions on what is persistent sleep apnea, then the role of upper airway evaluation, and I will finish with some treatment strategies with a focus on the treatment of children that are overweight or obese. So there are two recent papers on persistent obstructive sleep apnea that try to give some definition on what is this exactly. And both base their definition on polysomnographic data. In the paper by Refika Ersu, persistent sleep apnea is defined as an obstructive apnea-hypopnea index more than 1.5 on polysomnography. And in the paper by Stacey Ishman, the apnea index is combined with symptoms, or when it's more than 5 per hour, this is also considered to be persistent sleep apnea, regardless of whether symptoms are present. Nevertheless, we all know that there are some limitations to use the obstructive apnea-hypopnea index as a single metric to define the severity of obstructive sleep apnea. And several studies have pointed out that we also need to consider the clinical symptoms and the symptom burden. And to do this, we can use questionnaires such as the Pediatric Sleep Questionnaire, the part on sleep disordered breathing, or the OSA 18 questionnaire, which is a questionnaire to assess the quality of life. Furthermore, we have to take into account that the pathophysiology and also the end organ morbidity of sleep-disordered breathing may vary with age, and these are factors that we also need to take into account when we make our treatment decisions. There are several challenges which are related to persistent sleep apnea. As we have already heard by Dr. Benedek, adenotonsillectomy is still considered the first-line treatment for sleep apnea in children. Nevertheless, we know that up to 70% of children with underlying conditions, such as obesity, craniofacial disorders, or medical complexities, will have persistent sleep-disordered breathing after adenotonsillectomy. And this poses a burden not only on the child, but also on the family. It might result in long-term neurocognitive deficits, problems at school, learning difficulties, problems with attention, reduced quality of life, emotional problems, and also cardiovascular and metabolic problems. So overall, this comes along with an increased healthcare utilization. Another challenge is that there is a wide practice variation in the follow-up after adenotonsillectomy. And this is absolutely not standardized. It can be done online. It can be done just by a phone call. For instance, the nurse calls the parents after a few weeks or months. And sometimes you can do a repeat polysomnography, which is mostly limited to specific clinical scenarios. And I will discuss this furthermore. Also, we know that there is an increasing prevalence of children being overweight and obese. This is not only a European problem or a US problem, it's really a worldwide problem, and it raises up to 7 to 22% in high-income countries. And we know that obesity is a major factor that contributes to sleep-disordered breathing and to persistent sleep-disordered breathing in these children. So, which recommendations are available on the follow-up after adenotonsillectomy? In the paper by Stacy Ishman, it's stated that you should consider to repeat the polysomnography after any medical or surgical treatment for severe sleep apnea with or without symptoms, and consider polysomnography in children with mild to moderate disease if they have persistent symptoms. On top of that, a repeat polysomnography is recommended in all children that we know are at risk for persistent sleep apnea, such as those with Down syndrome, obesity, and the craniofacial anomalies. Unfortunately, polysomnography is not yet widely available or everywhere, but there are few data on the value of, for example, home sleep studies or oximetry for the assessment of persistent sleep apnea. Another question we have to ask ourselves is persistent sleep apnea the same as failed surgery? Because we often see that children after adenotonsillectomy have a significant symptomatic improvement despite the fact that the polysomnography is improved, but there is no return to the so-called normal limits. So in this case, we should consider what we want to obtain. Do we want to have this number, this figure of the apnea-hypopnea index below the defined limit, or do we want to have an improvement in symptoms and in comorbidity? Another question that raises is, can we predict which patients are likely to have an incomplete response before we start with the treatment? And this is very important because then we can counsel the parents and we can set realistic expectations. For example, if we know that a child with Down syndrome and with obesity will undergo an adenotonsillectomy, we might do some complementary examinations such as DICE, and based on this, we can predict that it's very likely or unlikely that the child will improve enough after adenotonsillectomy. And if you can tell this and discuss this with the parents before you start the treatment, this would be more appropriate and really part of shared decision-making approach. Which factors then contribute to persistent sleep apnea? And I cannot go into detail, but we have already a lot of knowledge that sleep disordered breathing is more than just adenotonsillar hypertrophy. Many factors come into play. You have, of course, this compromised upper airway, but there might also be alterations in neuromuscular control, changes in ventilatory response, changes in arousal threshold, and the relative contribution of these different factors may also play a role in the persistence of sleep disordered breathing after adenotonsillectomy. This was also already pointed out by Dr. Benedek that there are different phenotypes of pediatric OSA, and also we know that according to the phenotype, there might be a better likelihood of improvement after adenotonsillectomy. I will not go into detail in the role of drug-induced sleep endoscopy because of time limits, but if you are interested, I can recommend you these two papers that have been recently published and that will explain the role of DICE in the assessment of the upper airway before we start treating our children, especially those where we believe that they have an increased risk for persistent sleep apnea after adenotonsillectomy. What we learned from DICE is that multi-level obstruction, meaning obstruction also outside of the adenotonsillar region, is very common, and it's present in more than 50% of the children with obstructive sleep apnea, and it's also associated with more severe sleep apnea, both in terms of apnea index and also with lower oxygen saturations. DICE examinations have also shown that tongue-based obstruction, with or without lingual tonsillar hypertrophy, and laryngomalacia are very frequently the cause of persistent sleep apnea. And especially tongue-based obstruction has been increasingly been identified in children with persistent sleep apnea. And here you see some examples of a child where the tongue base is really pushing the epiglottis against the posterior pharyngeal wall. And here you see a child with enormous lingual tonsillar hypertrophy that would be the reason for persistent sleep apnea. So what can we do in the terms of the management for persistent sleep apnea? Of course, we can perform DICE-directed surgical treatment. So we use the DICE to identify the sites of persistent sleep disordered breathing. And as we then see that tongue-based obstruction and laryngomalacia are the most common sites of persistent disease, it's not so surprising that tongue-based surgery and supraglottoplasty are the most common performed surgical procedures. They result overall in an improvement, but with success rates of about 61%, both for tongue-based surgery and for supraglottoplasty. So again, we do complementary surgery, but complete failure is not obtained in all the patients. You can perform nasal surgery to address turbinate hypertrophy, or you can do soft palate surgery in selected cases. So when we look to the studies that looked at the outcome of DICE-directed surgical complementary treatment, it's clear that in most studies there is an improvement in OSA symptoms, an improvement in OSA severity based on polysomnography, and an improvement in quality of life. But nevertheless, it rarely results in a complete cure when you look to the figures of the apnea-hypopnea index. What can we do else? You can do bariatric surgery, especially in obese adolescents. Hypoglossal nerve stimulation has been shown to be very successful in Down syndrome children with persistent sleep apnea that are CPAP intolerant, and good results have been obtained both in terms of control of sleep disordered breathing with a good treatment adherence. Craniofacial surgery might be indicated in children with craniofacial malformations, and tracheostomy is usually reserved for children after failure of all other treatment options. CPAP therapy is certainly something that we need to consider in children with persistent disease, and this can be CPAP or bilevel BPAP. Here the discussion is, what is good treatment adherence? And in adults, usually one says that treatment adherence is good when the patient uses the device 4 hours per night. It's clear that in children who overall sleep much longer than adults, 4 hours is not enough. So 6 hours or maybe 8 hours might be needed, depending on the age of the child. In a very large study by Bhattacharya and colleagues, they looked at the daily use and found that it's on average about 4 hours. And that low adherence is especially prevalent in the young children and in the adolescents. They also concluded that if you have a good patient engagement program, this is associated with a better adherence. And patient engagement program, this usually means that there is a very strict follow-up of the patients by dedicated nurses or ventilatory therapists that contact the parents, that help the parents to accommodate to the treatment, that use training for parents and follow-up. And then you can achieve very good adherence, which is also shown in this graph. So you see the active use of the CPAP treatment was much longer in the long term in those patients that were enrolled in the patient engagement program listed here in this blue line. Other treatment strategies that you might consider and that usually are available when you work really in a multidisciplinary team are high-flow nasal cannula. Positional therapy can play a role, especially also here in obese patients. They're more likely to have positional sleep apnea. Rapid maxillary expansion or orthodontic treatment might be indicated, especially in children with craniofacial malformations or where there is really malocclusion or a very hard arch palate. Myofunctional therapy might be an adjuvant treatment to CPAP treatment, and it's considered to be minimally invasive, although also here treatment adherence might be rather low in the long term. Nasal steroids could play a role, especially in children with mild sleep apnea. They can also play a role to improve nasal breathing and to improve CPAP tolerance, because if the patient's nose is blocked, he will not tolerate the device. And observation might be an option in children with persistent sleep apnea that do not have many symptoms. Just the last few words on the role of the management of OSA in children that are overweight and obese, because obesity is second to adenotonsillar hypertrophy as the most important contributor to pediatric obstructive sleep apnea. And by this, we have shown that this pattern of circumferential collapse is very common in children with obesity, and it's also associated with persistent sleep apnea. And this circumferential collapse might be more difficult to treat, especially with surgical modalities. So what can we then do? We see that persistent sleep apnea is highly prevalent in these children. Of course, nutritional counseling and exercise programs are important. Stacy Ishman and colleagues discussed that PAP treatment should not be the default option, but really emphasize the importance of a complete upper airway evaluation, also in obese children with a persistent sleep apnea. They pointed out that surgical candidates might prefer surgery as an alternative to CPAP, but this should come along with caveat, because we also know that obesity has been associated with poor outcomes, and this has been shown especially after tongue-based surgery in children with Down syndrome. So on one hand, we could consider additional surgery in obese patients, but we have to acknowledge that the obesity on itself might be associated with poorer outcomes of our treatment. So here again, the multidisciplinary approach and discussing with the parents and the child the different treatment possibilities seems very important. And this is very nicely shown in this figure, in this excellent paper by Rifika Ersu and Indra Narang, where they emphasize the importance of shared decision-making in the management of persistent sleep apnea. This is a list of references that you will have for review. And also I would like to invite you, we can discuss this further at the ESPO meeting in Stuttgart, and I hope to see you there. Thank you for your attention.
Thank you very much, Professor. It was an amazing presentation. And now the last speaker is Dr. Giovanni Camarotto. He is an ENT consultant and sleep medicine doctor at Hospital Morgani in Forlì, Italy. He earned his PhD from the University of Messina, and he established himself as a dedicated clinician and researcher in the field of sleep medicine. Dr. Camarotto's work focuses on diagnosing and treating OSAS, and he also works on integrating innovative technologies into clinical practice. Please join me in welcoming Dr. Giovanni Camarotto, and thank you very much for joining us tonight.
Hello, everyone. First of all, thanks, Vlad, for the invitation. Thanks, Young European Confederation, for the opportunity of talking about a topic that, in my opinion, is thrilling because great news are coming, and we have to talk today about the capacity of artificial intelligence in helping us in the diagnostic moment of sleep apnea. And first thing first, we have to see artificial intelligence where it is moving, what is the territory, the background. And as you know, the definition of OSA in children is different from adults. We just need one event per hour to say that the patient has got a sleep apnea or a pattern of obstructive hypoventilation, but I don't want to talk about this. There is the AASM manual that tells you how to diagnose sleep apnea in children. Also, the severity scale is different from adults. The degree of desaturation and hypoventilation may modify severity, and the OSA in children is typically REM-related. In adults, can be also non-REM-related, as you know. The main question is performing PSG type 1 PSG to all children feasible? There are differences in healthcare system. Access to this kind of examination can be complex. Also, performing a type 2 polysomnography is very difficult because children needs to be monitored, otherwise they take off the sensors. So maybe the technology and the improvement in artificial intelligence can help us in going over this burden. But we have to follow the guidelines, and the guidelines tell us that the PSG is indicated when we want to diagnose OSA in children. And especially if we want to perform a surgery, this is indicated by these guidelines, and also as a follow-up in children on PAP, is very important to make them undergo a full polysomnography. In Europe, things change a little bit because when they talk about PSG, they talk also about type 3 polysomnography or polygraphy or cardiorespiratory monitoring, as you prefer. So they give another option, which is, of course, more feasible, but then again, also the problem of access can present again. But they say in these guidelines that previously untreated or otherwise healthy non-obese children at risk of OSA and planned to undergo adenotonsillectomy for hypertrophy of the adenoids and tonsils are of low priority for polysomnography. So there is some possibility to maybe find other ways of diagnosing these patients and stratifying the risk of OSA and then propose a treatment. We have to think about other modalities, screening tests, and also talk about economics that in this very moment is very important for our healthcare system that are suffering. And of course, oximetry has some limits, we know, but can be very easy to perform. And in this paper is very well highlighted that nocturnal oximetry can help in the identification of OSA in children with high pretest probability. So there are patterns of the exaggeration that can help us to identifying OSA patients, and we use McGill oximetry score that can tell us if the patient could be mild, moderate, or severe. There are studies evaluating the predictive value of the oximetry in diagnosing OSA patients, and we see that a normal or 2 score, McGill score, doesn't rule out OSA. So PSG is always required because the false negative, so the sensitivity can be low. So we need to improve this kind of data. We need a more reliable way of diagnosing OSA. So maybe AI can help us. And how is it impacting in OSA detection? We are living in a era of the wearables. These are several kinds of wearables. Of course, we're not talking about specific OSA wearables, but what we know from these devices is that they can be applied on large scale. They allow us a continuous recording of information, and this maybe can be the way to learn on how to diagnose in an easier and cheaper way OSA, and also in children. I would like to go through some devices available in the market. It's not publicity, but I would like to talk about each characteristics. The Aura Ring is very popular in the United States. It works with 3 main sensors: infrared photoplethysmography to score the heart rate and the heart rate variability and respiratory rate; temperature sensors that can help us to understand if the patient is awake or not; and 3D accelerometer, also useful to understand the wakefulness and sleep. There are several parameters coming out from these recordings, and overall sleep score that tells you if the quality of the sleep is good or not. Samsung Watch, here is the last model, is more complete because there are more channels of recordings, accelerometer, gyroscope that tells you also of the angular acceleration and gives you a better understanding of the movements of the patient during sleep, optical heart rate sensors. Here we have a saturation sensor, which makes it more complete; temperature sensor and the snore detection by means of the microphone. So also the pitch detection can help us in understanding if there are some events. This device is FDA approved. There are studies that led to the approval from the FDA, especially the approval was for patient users over the age of 22, not diagnosed with sleep apnea, but to detect those signs that predict for moderate to severe OSA in the recordings of 2 nights. This doesn't mean that this device is cleared for diagnosis of OSA, but this means that the positive outcome from this device is reliable and is an indication for performing a proper sleep study, and this is very helpful in rising the awareness on sleep apnea among normal users. Apple Watch has also been recently approved by FDA. The sensors are similar. They have also the capacity of recording the ECG, because the Apple Watch has got a sensor on the back of the watch, another one on the sides that leads you to record a 2-lead ECG. So this gives you also some more cardiac recordings. Again, here you can see all the kind of information we can get from this kind of device. We have to know what is artificial intelligence. Artificial intelligence is basically a set of technologies enabling machines to perform complex tasks that generally are performed by humans. There are actually several applications available at the moment in the market for several specialties. In radiology and dermatology is widespread. Now also in sleep disorders there are things going on. I will show you soon. AI can let you process large data sets very quickly, and also identifying hidden patterns, so things that you can see at the first sight, but the model, if it's properly designed, can help you in highlighting these spots. And it's apparently it's very useful for diagnostic, because it raises the accuracy. Application in sleep medicine, so can begin from the screening to diagnosis, and maybe, who knows, in the future also in selection of patients for certain specific treatments. We will see if we reach that moment. And wearables can be a way to record enough information to create those large data sets that can help us in the detection of OSA. And of course, reduce the burden of the traditional in-lab polysomnography. There are several kind of artificial intelligence model. Machine learning and deep learning are surely the most used, the most widespread. These machine learning models work without an explicit programming. You can see here two kinds of models, the unsupervised and the supervised. The difference is basically that when you use a supervised model, you label the data at the beginning before inserting the data in the machine, and then you have to add also some testing data in order to have more reliable information. The unsupervised machine learning works automatically. They have this kind of ability of detecting the hidden correlation or subtle correlation, and it can be applied, of course, for wearables or other electronic health records, for example, from PSGs. Deep learning is an evolution of the machine learning because it works with more layers of multiple layers of deep neural networks. So the manual work of the operator is reduced to basically to zero. Needs, of course, a good programming, a good designing of the model, and there is an automatic feature extraction. So generally, deep learning works better with big, large data sets. Machine learning is often preferred when we have smaller data sets. When we talk about OSA detection, as I told you before, we are talking about the use of wearables in order to collect continuous data and have more data. But there are studies also about the use of an artificial intelligence model on drug-induced sleep endoscopy, and also on biometric data or PSG data in order to predict or detect sleep apnea, and we will go through these papers soon. First of all, I would like to show you this very significant review collecting 132 studies included, talking about the use of machine learning models in the diagnosis of sleep apnea. As you can see, these models use mostly the electrocardiogram, pulse oximetry, and sound signals. And they proved to be very effective in detecting apneas, differentiating apneas obstructive from central, also classifying the severity of the syndrome. So this kind of model looks promising. This paper by the group of Nick Conan evaluated the capacity of an artificial intelligence model to score obstructive sleep apnea event on PSG recordings, and basically they saw that the accuracy, so the accuracy is a measure of the capacity of prediction of the events, but the capacity of prediction was very good for in differentiating non-OSA from OSA, and also in detecting severe OSA. Was lower for mild to moderate OSA because the range of severity is different. As you know, mild OSA is between 5 and 15, moderate is from 15 and to 30. Instead, we have a larger interval when we talk about severe apnea from 30 to as higher as we want. So there is a difference in the accuracy, and also the capacity of detecting hypopnea was lower in comparison with the apnea, because the signal is more complex to interpret, and in this kind of model proved to be to score shorter events, short epochs, in comparison with manual scoring. And as you can see on the right side, we have two images of events. In the upper one, the artificial intelligence model scored an apnea shorter than the manual scorer. Instead, on the one on the bottom, the artificial intelligence model split an epoch into two events. It was just an apnea, but the machine learning model scored an hypopnea and apnea, making an error. So there is still room for improvement, and of course to improve the accuracy in detecting each event, and also classifying the patient properly. This is the paper I was talking about before, the application of a deep learning model for the detection and the scoring of obstructive events in drug-induced sleep endoscopy. This paper showed that there was more concordance in the scoring obstructive events at the level of the villum more than other sites. But the problem of DICE is that the inter-rater agreement can be low also between experts, as shown in other papers. So maybe it's also a limit of the procedure itself. But when these authors compared their experience with the artificial intelligence model with other papers, they saw that there were papers where the inter-rater agreement was lower than what's seen in the artificial intelligence experience. So this means that the results was not really far from the actual practice in our hands. There is, as I told you, there is still room for improvement, because several groups are focusing their attention also on recording other kind of signals in order to diagnose sleep apnea. This is basically the assessment of audio-based snoring features, so from the sound, pitch, intensity, frequency evaluation, you might be able to score an hypopnea or an apnea. Again, there are other signals, for example, the most famous peripheral arterial tonometry, apart from Alan Schwartz research, is widespread in several countries. So what are the challenges and the limitations at the moment? We need larger data sets to create a more reliable model that can be machine learning or deep learning. There are still some issues in terms of privacy and security, and there is a big problem that is called black box, because sometimes these models give you an answers that we don't know where they come from. What is the mechanism that bring to some answers from machine learning and deep learning models is still debated from experts in informatics. There are ethical concerns about the use of these models without supervision of humans, but this is a problem applied to all the world of artificial intelligence at the moment. The future is for sure focused on detection of new signals. Who knows, maybe also a better understanding of oximetry. As you know, there is a big focus at the moment on the role of hypoxic burden. So it's a relatively new score that allows you to maybe better stratifying the cardiovascular risk in OSA patients. I'm talking about adults. The experience on pediatric OSA is still very little, but maybe the application of models also in detecting hypoxic burden can be very interesting to evaluate. And we need easy and repetitive recording. So this kind of wearables can be very interesting, and the application of artificial intelligence algorithms really match in a very easy way with wearables, and they need to be developed. So we have to work side by side with expert in AI in order to also satisfy our needs as clinicians. And thank you for your attention.
Thank you very much, Giovanni, for your presentation. And thank you all for participating. Now I have a series of questions. So everyone is invited to answer if you want. First of all, I would like to ask you if there is a guideline or there are recommendations for food and drink after surgery, tonsillectomy or tonsillotomy.
So I think there is not a widely accepted guideline. It depends on the countries and the local preferences. So in our practice, we usually recommend fluids and soft foods for the patients for the first few days, and there are not other recommendations for foods and drinks in our practice.
Yeah. I just would like to add to that what we emphasize is that painkillers should be given before the meals, so that for example, give them at least 30 minutes before you plan a meal, so that the child has no pain at the time of the meal, because if they have pain, they will refuse eating and drinking, and then this also impairs the wound healing. So it's probably more important that you give the painkillers at the right timing than what you actually give them as food.
Thank you. Thank you. A very, very interesting answer. There are some few other questions. Are high loop gain apnea events observed in children? And another question also about this, if there are AI tools available for identifying cases of high loop gain events.
Well, an increase in loop gain has been documented. There are some studies in children with Down syndrome, for example, where high loop gain has been documented, but it's very difficult to diagnose. So that is one of the limits. In adults, tools have been developed to measure loop gain, but in children, it's very hard to apply this in routine. And I am only aware of some studies in Down syndrome children. Now, sometimes from the polysomnography, you could interfere. For example, if children really start to have cycles of central apneas at the moment of the transition from wakefulness to sleep, etc., then it's more likely that they have a higher loop gain, but it's very hard to measure this at present.
And maybe the second question about the AI tools. There are not AI tools available today, but it's interesting that these kind of models can see what we cannot see. So the interpretation of this instability in the respiratory flow, which is the eye loop gain itself. Maybe these kind of models can find a way to see the eye loop gain better than us. So it's really interesting to see what will happen soon in order to get this kind of application of algorithms for PSG interpretation that can let us endotype the OSA patient better. Which is one of the main limitations, because endotyping at this very moment looks more like theoretical than practical. So we need to make it easy. And when I spoke about wearables, maybe we will find a way to get this kind of information in an easier way.
Thank you very much. And one last question. If you think that comparison between pain after tonsillectomy and tonsillotomy have some middle ground, and if the patients should choose or the doctor should propose. Because I also have in my experience a lot of doctors that come to me and say, oh no, I want that type of surgery and I don't want the one with the pain for my children and everything like that.
Sorry, what is the question exactly?
If there is, if the patient should be able to choose or not, because there are doctors for example, in Romania that are in the public hospital that are not doing coblation surgery due to the price, and patients avoid surgery because of the pain, for example. And since the price is a big problem in some systems, they use the old ways of surgery, for example. And what should we say to the patient, to the parents, actually?
You mean that if a patient could choose between the tonsil surgery, so what will be
Yeah.
so I usually discuss with the parents about the type of the surgery. In our practice, I don't use coblation for every tonsillotomy. So I usually perform radiofrequency tonsillotomy, but sometimes some of our colleagues do it in cold way as well. So it not depend only from the methods. So you can choose between the methods and you can do tonsillotomy in other way, not only for the coblation, and it not depends on the price. We usually discuss it with the parents. We discuss the short-term effects, of course, and the long-term, the regrowth rate as well. But this 4 or 6% regrowth rate is not as high as they choose the tonsillectomy above the tonsillotomy.
Okay, thank you. And one last question that I received is, if the child is obese, should we wait for surgery after he loses some weight, or do it and see if he manages to lose weight or not?
No, we use, if there is an indication for surgery, we will discuss this with the parents, but on the same time, they are in a weight loss program, so we do both together. And I think especially if you remove adenoids and tonsils, we know that there is an increased risk for weight gain after the surgery. This is nice in lean or in small for aged children, but especially in the obese patients, you have to counsel the parents about this. But if there is a clear indication for adenotonsillar surgery, we would do this, and along with weight management and physical activity. Yes, because often if they improve a little bit or apart, they feel better during the day, and this would also encourage them to be more active, to more engage in physical activity. So then you can, that makes it more easy. Yeah. But you should counsel for weight gain after tonsillectomy. That's very important.
I just wanted to add some word about the weight loss and obesity in patients with sleep apnea. So without the surgery, without improving the sleep, the patient can't be effectively lose weight. So without without the deep sleep phases, without the hormonal changes, they can't lose weight. So we need to do the surgery and of course the weight loss program together. But without the surgery, the weight loss program won't be effective.
Okay, thank you very much. So the time has come to the end of this webinar. Thank you very much for these amazing talks, and thank you very much for all the participants that were here, and also thank you, Young European ORL and HNS Confederation. Thank you very much all, and hope we will meet you in the next Congress. Thank you.
Thank you.
Thank you very much.
Thank you.
Bye-bye. Have a nice evening.
Bye-bye.
Bye.